week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
I would like to introduce Margaret Maddox, a PGY2 emergency medicine resident at the University of Illinois, Chicago. She's going to be talking to us today about a double-blind randomized crossover trial of low-dose Flumazenil for benzodiazepine withdrawal.
And today I will be doing my journal club on low-dose Flumazenil for benzodiazepine withdrawal, and it's by McDonald and colleagues. So first, we're going to look into the background of benzos and why we kind of care about benzodiazepine withdrawal. Looking at benzodiazepines, it is currently the most prescribed medication for psychiatric conditions ranging from anxiety to mood disorders, and it's the third most misused drug among both adults and adolescents and continues to rise each year. Approximately half of patients are usually on benzos for greater than a month, and those patients will then experience some type of dependence to it. We think that this is due to benzodiazepines having some effect on the dopaminergic pathways due to its modulation of GABA receptors. So we kind of get that reward from the action on the dopaminergic neurons. And then patients that are taking short-acting benzos will typically have a worse withdrawal or a quicker onset of withdrawal symptoms than those taking long-acting. So those that are on short-acting might experience withdrawal symptoms within 2 to 3 days, and then those that are on longer might experience it within 5 to 10 days. And then I have here withdrawal symptoms are it's a wide variety that patients can experience, but it's typical to other drugs of misuse. It includes agitation, depression, tremors, sleep disturbances, and then also disorders of perception, and then seizures are also common among benzos. Looking at treatment and kind of the background of benzodiazepine withdrawal treatment, there's been a lot of medications that have been looked at to try to mitigate some of these withdrawal symptoms. Even like beta blockers are sometimes used for like the acute symptoms like agitation and tremors, but nothing really for the overall withdrawal symptom profile. Flumazenil has been looked at for a while now. It's historically noted as a GABA receptor antagonist, so doing the exact opposite in a way of benzodiazepines, but there is some thought that it could have a different mechanism of action that we can get into later. And typically in these past studies, Flumazenil has been used at doses between 1 to 4 milligrams over 24 hours over the course of multiple days. That's also been given as an IV bolus, so in a shorter duration of time. And then most recently, it's kind of been looked at as a low-dose sub-Q infusion. So now talking about the study objective, this was a pilot study, so really it was aimed at collecting data based off of the safety and efficacy of low-dose Flumazenil to reduce benzodiazepine use and withdrawal symptoms, in addition to craving scores within participants. And they particularly looked at patients that were already taking the therapeutic maximum diazepam equivalent, which is 30 milligrams daily. Then moving on to our methods. This was a randomized double-blind crossover trial over the course of 16 days, and it took place at 2 Australian treatment clinics, both in the outpatient and inpatient setting, so not like a controlled detox environment or anything like that. It took place from July 2017 to June 2019, but each patients were only randomized for a total of 16 days. Moving on to our patient selection, our participants that were included in this study, they had a daily benzodiazepine use greater than 3 months. They had a daily benzodiazepine use that was greater than 10 milligrams of a diazepam equivalent per day, which is considered like the therapeutic range, and then a desire to cease benzos. And then the study excluded all patients that had a history of seizures due to Flumazenil. So if they had previously had a benzo overdose and had been given Flumazenil, that would really be the only way that we would know they were predisposed to seizures from it particularly. And then patients were also excluded if they were pregnant, breastfeeding, or less than 18 years old. So overall, the interventions, participants were randomized 1-to-1 between 2 different groups. It was stratified between placebo first and then Flumazenil low-dose sub-Q infusion first. So they would get that, whatever their first choice was, whatever they were randomized to first, they would be on it for 8 days and then they would switch, and that's how we get the crossover trial. Over the course of their infusion, they were receiving 16 milligrams of Flumazenil over the 8 days. So they would receive 16 milligrams over 4 and then another 16 over the next 4. And then the placebo also received an infusion, and then that was for 8 days as well. So each group was getting 8 days placebo, 8 days Flumazenil, same dose and everything. Throughout the trial, they were able to each day request up to 10 milligrams of a diazepam PRN without a max daily dose. So at a time, they could request 10 milligrams of diazepam, and there wasn't like a cap on how much they could receive in a day. To receive the benzo, they had to score 2 or greater on the CWAB, which is a modified scoring system similar to the CWA that we use for alcohol. It just has subjective, objective criteria that's similar, but a little bit different, targeting benzo withdrawal. And then another intervention that was important was patients that came in without already taking an anti-epileptic outpatient. All those patients were started on phenytoin 100 milligrams PO TID. So the study endpoints, mainly our primary objective is going to be looking at if Flumazenil would reduce benzo use during this detox, and we're going to compare it between 2 different groups. So people that are taking less than 30 milligrams of a diazepam equivalent outpatient, and then those that are taking greater than or equal to 30 milligrams of a diazepam equivalent daily. Our secondary objective was to explore changes in withdrawal symptoms and benzodiazepine cravings. That's why we kind of have these scoring sheets that we're also looking at. So trying to see how their symptoms and scores differ throughout the progression, and also looking at the difference between those that got placebo first, how their scores were, and then when they got Flumazenil, if there was a difference in the two. And then overall kind of study outcomes that are mainly addressed in the results and our tables. If you have the study in front of you, it's percent reduction in equivalent baseline diazepam or benzo use, and then percent reduction in our CWA scores, our craving scores. We also look at treatment-related adverse events, and then changes in benzo use across the placebo first group. So trying to see, did they require more benzos at one point compared to the other. Here I just have for reference images so that you guys could be familiar with what metrics we're using. Besides percent reduction in benzo use, we have the CWAB and the craving score. CWAB is going to be, like I mentioned, both subjective and objective, similar to what we use in alcohol withdrawal. Kind of just talking over, like, are they agitated? And then also looking at some objective measures like heart rate. And then our craving scores are mainly trying to look at intensity, frequency, and length of the patient's craving, and then rating it on a scale. So very subjective scoring sheet. For statistical analysis, first, I just want to point out that this was a study that was a pilot study. So we're not really going to have, it's not a huge study that's big on stats. It's kind of, we have a p-value that's used. You'll see it in our tables in the results section that they do report p-values, but it's not a powered study. So we really can't extrapolate too much from it. But for stats, I wanted to show this picture because it's what's included in the actual study. And it kind of just will go over what groups we're going to be doing our statistical analysis on. So we have 2 groups divided up here, but ultimately we're going to be doing stats on 4 total groups. So you have your Flumazenil first group, and they have the breakdown of the infusion regimen, which, as I said, with 2 16 milligram infusions over 8 days. And then they would switch to the placebo infusion, and then placebo first is going to get the placebo and then the Flumazenil. But within these 2 groups, then we further divide into 2 more, because then we start looking at, within the Flumazenil first group, we want to stratify those that were taking high-dose benzos outpatient, so 30 milligrams of a diazepam equivalent or greater. And then the other group would be those that were taking less than 30 outpatient. And then that will be the same for the placebo first as well. So we'll have Flumazenil first, high dose, Flumazenil first, low dose, and then placebo first, high dose, placebo first, low dose. Now moving on to our results. So ultimately, 28 patients were enrolled in the study based off of our inclusion and exclusion criteria. 2 were withdrawn. 1 was due to behavioral differences, and then the other was due to suspected self-harm. So they were taken out, and we had 26 left over. So as you can see there, 5 were in the Flumazenil first low dose group, 8 were in the Flumazenil first high dose group, 6 in the placebo first low dose, and 7 in the placebo first high dose. Now looking at our baseline characteristics, they reported a lot of characteristics kind of quantifying all the way from what their outpatient benzo was to what other kind of psych conditions they may have had that maybe precluded them to having the benzo on board in the first place. And then they also did look at other substance use outside of benzos, but I haven't read the kind of the most notable baseline characteristics that I want to talk about today. First is the diazepam equivalent. You can see that the flumazenil first group has much higher average diazepam equivalents coming at baseline. That is because that patient group had a wide range of 30 milligrams to 280 milligrams. Compared to the other groups, they had not such a wide range. I think the highest in the placebo first was 100 milligrams. So that's why you can kind of see some variability in the baseline diazepam doses that these patients are coming in with. And then also, I haven't read the length of benzodiazepine use in years, because a lot of kind of the research going into benzodiazepine dependence relates to not just dose, but also length of time that patients are on it. The longer you might be on it, even if you're past that 1 month mark of where we typically see dependence in patients, the longer you're on it, of course, the harder it's going to be to get off of it. So as you can see here in red, the placebo first groups do have a much longer average length of use compared to the flumazenil first groups. So I just thought that was something to kind of note, because we do correlate length of time as something as a more difficult factor to get patients off of benzos. Now moving on to our summary of outcomes for our first group, which is our participants that are taking less than 30 milligrams of a diazepam equivalent at baseline. This is table 2 for reference if you do have the study in front of you. I have highlighted in red the diazepam use. I feel like that's the most notable to report to result on or talk about. So we have here that in the far right column, change from baseline use is in percent. And you can see that the 32 is a positive number and the 45 is a negative number. So they don't really define how to interpret results, but it can be interpreted that the placebo first group had a 45% reduction in what their baseline diazepam use was compared to once the infusion was started and once the study kind of got going. Then in the flumazenil first group, we do see a 32% increase from baseline diazepam use. So that means that these patients were requesting more PRNs. They were also meeting the criteria to receive the PRNs, and they were going above their baseline coming in. And then we have here also withdrawal and craving, the results from those scoring systems from baseline to end of study. And if you do, I want to mention that if you do see like varying in values, kind of to the right of like flumazenil first and to the right of placebo first, that is because the study took out patients that had a low withdrawal or craving score at baseline. So if they came in with a low score, they just did not include them in this portion of the results. Now moving on to our summary of outcomes for the other group, meaning the patients that were on 30 milligrams or greater of a diazepam equivalent at baseline. Again, I have kind of in red the diazepam use because that's our primary outcome, is trying to reduce benzo use. So we have our percent from the flumazenil first group. We see a decrease in 75%. So these patients that were coming in on higher doses, and the results are reported to taking a lot less of the PRNs each day in comparison to those high doses. So again, we have, as I mentioned earlier in our baseline characteristics, this group was also the group that had a very high range. They had one patient taking up to 280 milligrams a day, but they still had a major reduction from this group. And then in the placebo first group, we also see a reduction of about 45%, kind of similar to the other group that was taking less than 30. And then again, they report withdrawal and craving scores here, but I have highlighted in red the withdrawal because you can see that there's kind of two different subgroups, which is different than what we saw on the less than 30 milligram outcomes. Just for these patients, they decided to stratify their withdrawal scores based off of those, as you can kind of see in the table below that I have on this slide. They decided to differentiate those that had withdrawal scores from mild to very severe and then moderate to very severe. So that's why there's two separate groups. They're just trying to further subgroup these patients and try to characterize if they came in maybe already agitated and in some type of withdrawal or already not meeting, like maybe they're already very tolerant and dependent on their current dose. These patients were already going to start at a higher score and we might not see as great reductions. Now moving on to the author's discussion and conclusion, and then we'll kind of get into my discussion and overall conclusion. So for the authors' discussion, they report that benzo use was significantly reduced, especially in the self-requested benzo use in this type of study for patients that were taking greater than or equal to 30 milligrams of a diazepam equivalent at baseline. There was no significant differences in withdrawal or craving. And they did report some limitations, that it was a small sample size. It's a pilot study. So again, we can't really extrapolate a lot of these results, and we don't have a lot of statistical tests or power surrounding them. And so then we might be prone to more errors. And then also they did mention that self-reported illicit benzo use can also be a weakness of trying to quantify really how much did their benzo use go down, or if any. And then future recommendations that the author states, try to replicate this in future trials in a more controlled setting so that we could kind of get away from just self-reporting illicit benzos or outside benzos, and then compare Flumazenil against a dose tapering rather than placebo. I do want to mention that this was the first trial of its kind to not just look at Flumazenil for low-dose subcutaneous infusion, but particularly because it was the first one that didn't have a simultaneous rigid dose tapering regimen going on at the same time. It was just allocated to PRN benzos. So the author's overall conclusion is that low-dose Flumazenil reduces diazepam use in participants aiming to cease benzos already taking greater than or equal to 30 milligrams of diazepam equivalent prior to treatment for at least 3 months. Now moving on to my discussion, what I really took away from this study. I have a lot of thoughts, and I'll just kind of walk through what my thought process was when I was kind of analyzing this article. First, there was a really vague definition of the infusion dosing regimen. I had in that picture that was the only way that this study really explained the type of regimen that we would be using. For me, it was really difficult to understand. I couldn't understand if we were getting 4 milligrams over 24 hours and that extended to 96 hours. I just wasn't quite understanding it. And even in the text, it was a little bit difficult to fully wrap my head around. There was an additional study that they put out kind of looking at 3-month outcomes. And they do very concisely and clearly mention the dosing strategy for this study in that paper. So that's how I can clearly say that it is a 16 milligram infusion twice over in 8 days. Also, there's a lack of defining benzo use during treatment. We just kind of know that the patients are able to request these PRN benzos. There's no cap on it. They have to meet certain criteria. Considering there's such a low number of patients and they did a lot of subgroups already, I guess I would want to know kind of what was the benzo use like. Like I kind of want to just know, like, were they requesting like 5 PRNs a day or 10, just out of general curiosity. Also, clearly a limitation that also the author commented on is self-reporting outside benzo use. This doesn't just have to be illicit benzos. It could be, they're taking more than maybe they're telling you is prescribed to them, or they're just doubling up their prescribed dose. I just feel like that's kind of difficult to, if our primary outcome is to quantify reduction in benzo use and we're using self-reporting methods, it's kind of hard to quantify if we really met that or not. Also, they did not assess patients with low baseline withdrawal and craving scores. I kind of mentioned it in the results. Maybe was already giving off my feelings of that. It's a little weird to me that there's like 2 subgroups in one portion of the results and then not a subgroup in the other one. They just decided to like delete some patients. I think that even if they started with a low baseline withdrawal and craving score, like what if they had developed a higher score, then that could key us into something. So I thought that really didn't make any sense. It's not replicable in most outpatient settings. I didn't really touch on it in the PowerPoint, but if you did happen to read the study, they did use this very specialized pump for the outpatient setting that we could administer this low-dose subcutaneous infusion. I feel like at most outpatient settings, that's not going to be very replicable or applicable to most sites, especially budget-wise, considering maybe there's a low number of patients coming in for benzo withdrawal every year or something like that. I also kind of touched on this earlier, unclear definition on how to interpret the results. You can just pretty much put 2 and 2 together, that plus equals increase and then negative equals decrease. But they really don't say how to interpret the percent of benzo reduction. So that's just something that I feel like deserves some commenting on. There was also an unclear reasoning for the withdrawal groups in the greater than or equal to 30 milligram group. So they didn't really explain why in just the high dose group, why they decided to divide the withdrawal groups into 2 separate groups, but didn't do that for the less than 30. They just kind of mentioned that, they took some out for the less than group because they started low, but they didn't mention the need for having 2 separate withdrawal groups within the high dose group. Also doesn't really talk about the purpose of the crossover study. I'm still a little bit confused as to why we do Flumazenil first and placebo first and then have a separate group for placebo first, Flumazenil first. They don't really say what they're trying to get from that study setup. So I would just kind of like to know some of the reasoning. It might be really valid reasoning. It's just maybe not easily understood. And then there was no washout period. So even doing this like placebo first, Flumazenil first, whatever came first, there was no washout between the 2 infusions. So really can't tell if it's lingering effects, if it's any effect from the previous one or this new one. I just feel like a washout period is really needed if we're going to do 2 separate measures within the same time frame. So ultimately, my conclusion is that what everyone always says, but it needs further investigation. And I do mean that because I think there's a lot into Flumazenil potentially. There's a lot of study kind of going into it, I feel, like trying to understand the mechanism of action, especially for benzo withdrawal and not benzo overdose, trying to see how its use could be potentially applicable to these patients. But I would particularly want to see it in a controlled detox environment, at least at first. Of course, that's not, everyday, day-to-day life. Patients are in a controlled setting, but I think to try to get a first pilot study, I would want to see it in a controlled environment or an inpatient facility where we have better control on outside benzo use. Definitely a larger sample size, a cap on the daily benzo PRNs, and then less patient subgroups, or at least explanation of why we have subgroups, and mainly only do subgroups if you have a larger sample size. So will this change my particular practice in RED? No. I think it's a unique idea, and I think there's a lot that could be done with Flumazenil, but I think there's still a lot that has to be looked into and have proper study set up. And I just want to acknowledge my mentors, Dr. Frank Polachek and Dr. Renee Petzel, for helping me get through this journal club. Thank you.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for a review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.